I'm Dr. Rovinsky. I'm from University of Hawaii. I've been doing the direct anterior approach for 10 years, and I think that the major advantages of this approach are restoring leg length and offset with precision. And I've been using the HipGrid to help me with that, and I find that it gives me very precise information from which I can make decisions. In this case, we're going to look at a 70-year-old gentleman who had a right hip intertrochanteric fracture, and it was fixed with a trochanteric femoral nail, a TFN, and he went on to have avascular necrosis. And the decision was made to proceed with a total hip replacement. And this is not uncommon, where you have to deal with a situation of revising a TFN and also dealing with kind of distorted proximal femoral anatomy, where the lesser troch's been pulled off, and you have to use other landmarks. So I'm going to show how we use the HipGrid to get the leg length and offset correct in our revision surgery. The first step is getting the TFN out, and there is a bit of a technique to this. A lot of people want to rush and take out that distal interlock screw, but you need to stabilize the rotation of the nail to take out that superior set screw. This allows the spiral blade to become free, and you can back it out. Now is the time to go ahead and remove that distal screw. And to get the nail out, I find it difficult to thread in the proximal locking guide because there's often a lot of bone overgrowth. So I use a crochet hook, pass it through the nail, grab hold of the nail, and then back slap it out. Now we're dealing with a regular total hip replacement. The TFN has been removed through other incisions. After cutting the femoral neck, we want to get a good AP pelvis, make sure the hip is level, and then we line up the HipGrid so it's across the teardrop, so we have a good starting point and good information to work with. This gives us a frame of reference for reaming our acetabulum. So just like any regular hip, we're going to medialize until we hit the ilioischial line, and then we're going to ream it in about 40 degrees of inclination. You can use this grid to help you get your cup inclination correct, and you want to split the difference between 35 and 45 because our goal inclination is 40. I look directly at the cup and feel the anatomy to make sure I've got my anteversion correct, but you can get some additional information by looking at the C-arm image as well, and you want to see about a third of the cup. And this is what an ideal cup position should look like. After I finish broaching my femur, I take a quick shot at the femur to make sure I have good broach fit and fill, and in this case I want to make sure my stem goes past that distal screw hole. So I'm very happy with the stem size, and I want to make sure my leg lengths are in the ballpark and that I can match my leg lengths and my offset reasonably well using different head lengths. So I put my final stem in, and with my trial head I feel like I'm very close but maybe a little bit short. And I don't totally trust this information because my lesser trochanteric anatomy is so distorted. So we get an AP of the uninjured hip, and we're going to center the HipGrid on the teardrop, and we're going to look at where the HipGrid hits the greater trochanter. And we get a picture of our injured side, and this gives us an idea that we're in the ballpark but maybe a little bit long. So this affects our choice for our final component implantation. And in this case, we're very confident that we've restored our leg lengths and we've restored our offset. Our final x-rays confirm that we've restored normal anatomy. And I always take time to measure my cup inclination after I put the cup in to make sure that, again, the information I'm getting intraoperatively matches what I'm seeing postoperatively. And this is important also in the shoot-through lateral of the hip to make sure you got your anteversion correct as well.